Hi, my name is Jerry Hesch, and I have developed a very unique approach to treating the pelvis, the sacroiliac, and it's a significant departure from the muscle energy tradition. And the biomechanics of the muscle energy technique comes from the osteopathic profession, and it was fully articulated in 1958, at which time we had the only imaging tools they had was X-ray, and a lot of this was based on visual observation and palpation. Now, we've certainly learned a lot more regarding the pelvis and sacroiliac joint since then. In 1981, I took my first job with Richard Dunn Technique up in Havre, Montana. And at that time, he had published several articles on the sacroiliac joint, and so it took me a while to understand his approach. And at night, I would go for a swim at the university and go to their library. And I read that the shock absorber properties of the SI joint describe a main function of that joint. And so I started to evaluate it in the same way that I would evaluate the shock absorber on my car, and went on to develop a large number of passive spring tests. And the traditional model of teaching spring tests is to load a joint until motion stops. So here's an example. I'm extending my MP joint and my index finger all the way till motion stops, and now I'm going to give it a little thrust. And so the traditional model grades the mobility based on that thrust. The Hesch model is different in that I like to appreciate the recoil. So I take up the slack similarly, and now I'm going to thrust it, but I'm going to keep this force steady. Okay, so let's say it takes 5 pounds to extend the MP joint to an end point. It's called taking up the slack. Then I will keep that force even beyond the thrust. So now I'm going to thrust it, and I keep that force there, and it dampens it a little bit such that I can appreciate the recoil. And that's very, very informative. So I went on to discover that there are a large number of patterns of pelvic mobility dysfunction that are not described in the muscle energy technique osteopathic model, and I developed evaluation and treatment thereof. So let me get back onto my notes. I had several injuries as a child and a horrific motorcycle wreck at age 17 and a gymnastics injury. And in response to that, of course, I tried to seek treatment and found the limits of the traditional models of care and even non-traditional models of care. And I had a symptomatic rib joint where the rib articulates with the transverse process. And no one could help me with that pain, so I decided to try and treat it myself, and I was 17 at the time. So I took a rubber ball, and I found that a tennis ball was too soft. So I laid on a rubber ball and I placed it over that tubercle of that rib, and I moved around until I found that sweet angle in which it felt like it would release. And I stayed on that about 5 minutes and resolved it. So I learned a couple of things: that you need the correct amount of force. If it's too much force, the body may be intimidated and may fight it, won't relax into it. So you need to find the correct amount of force, which is mild, and use a fulcrum and apply that in a specific direction, and then maintain that for a long period of time. Most of my corrections to mobility impairments are on the order of 2 minutes, but there's one unique pattern of the sacrum in which I actually take 10 minutes to correct it. All right, so that's a little bit of background information. And let me just catch up on my written notes, okay? Now, it's interesting that when you read a book on manual therapy, they'll talk about different ways of restoring joint micromotion, mobility. One of those is a high velocity, low amplitude thrust, which sometimes is best described as high amplitude, or oscillating the joint, or applying a steady protracted force. And although that's described in the theoretical section, I don't find any manual therapy books that actually teach you how to impart a small force for a sustained period of time. So unfortunately, we don't have gobs and gobs of research support of this method, but in my clinic, I typically see people 3 times, and the actual hands-on technique for restoring joint micromotion is typically what I call once and done. It's a correction. It's not an alignment that has to be repeated. It's not an adjustment that needs you to keep coming back. It's done correctly, and it resolves that micromotion dysfunction. Therefore, it's called a correction. All right? Okay. Now, in our profession, study after study shows us that there is poor inter-tester reliability. And so 2 clinicians will not agree on the findings. But there is some good research on the Hesch approach, the way that we teach palpation of the pelvis. And that study was done by Luann Olson, and she found that most of the tests have good, fair to good, intra-tester reliability. An intra-tester means that the same person reevaluating that patient at a different time will find the same presentation. Okay, so there's consistency there. And in my clinic, it's only me, so I don't need for 2 different people to agree. I need the same person to have good skill sets. So what makes our palpation better than the studies in the literature? Well, for one thing, we palpate flat parts of the anatomy. Okay, so in the front of the pelvis above the ASIS, there's a flat portion of the ilium. And when the person is prone, in the very middle on each side of the ilium at the top, there's also a flat portion there. There's a flat portion on the back of the trochanter. The entire pubic bones are flat, and palpating down the entire length of the pubic bone teaches us a lot more than the traditional model. It only palpates the crest and the tubercles at the upper third. Okay. In terms of how we do our movement testing, we do a slow load to take up the slack in the structure, and then we impart the same amount of force. And we teach that with bathroom scales. We teach people to perceive 15 pounds of force to load it, and then 15 pounds to spring it. And that came out of me testing the motion test with a muscle testing device called the MicroFet. That can be very, very helpful. If you practice applying these forces on a bathroom scale, it's nice to have the less expensive spring-loaded scale rather than a digital scale. Okay? So when we take up the slack, if we're able to push a structure to the end where motion stops, then at that point we can do the forward thrust and perceive the recoil. And that's a normal joint. Throughout the body, that's a very important joint property. It reveals both mobility and stability. Okay? What you will find is that when you are not able to perform the spring test, it's hypomobile, then consistent with that mobility impairment is also muscle inhibition. So they will test weak when you find hypomobility with that spring test. Okay? So there's a few different scenarios. One is which you can take up the slack and then you can't spring it. We call that hypomobile or lack of mobility. Another scenario would be that you can't take up the slack, it's stuck and you just can't. That meets the definition of hypomobility. And my use of the term hypomobility in my writings actually means stuck. It's not different grades, it means motion is stuck. And that's also very distinct, and I think that improves the intertester reliability. When you push on the middle of your wall, okay, then you might be able to load that and get a little bit of spring because that sheetrock will give a little bit. But if you come right over a vertical stud, then you're not going to be able to take get any movement in that structure. And so that's just another scenario. Another one would be in which you can take up the slack, but it might take up a little more slowly, okay? And that's an indication of hypermobility. When I treat somebody with a diagnosis of hypermobility syndrome, I slow it down, I take up the slack over a longer period of time because they have a greater amount of elasticity. Otherwise, I'll get some false negatives in that population, okay? So the other scenario would be that you can take up the slack and then you spring it and the excursion of the forward thrust is just greater. And that's an indication of hypermobility as well as a lack of recoil, okay? So if you can take up the slack and you can spring it, but it just stays there, it doesn't bounce back, or it bounced back quite slowly, mushy-like, then that's also a sign of hypermobility. Now the good news is that when we assign a joint as having a property of hypomobility or hyper, those are typically treatable conditions, especially in the pelvis. When you encounter those things, they are often modifiable by finding a specific direction in which motion is lacking. And when you restore that motion, you take away inhibition in the joint mechanoreceptors. So in tendon and in ligament and joint capsule, there are the type 3 mechanoreceptors that when they are stimulated, and if a joint is stuck at end range of normal movement, you will have greater tension in those structures, and that will inhibit muscle function. Many people in my clinic come and have had about 3 months of spinal stabilization exercises at a rehab clinic. I quickly demonstrate to them that, well, you are still weak. And we can muscle test them, such as in trunk rotation in one direction and find it to be strong, and then find the opposite direction to be weak. And strengthening doesn't restore normal micromotion in the body, but the body responds to typical injuries by losing that little bit of micromotion, and that in turn causes inhibition, okay? So muscle weakness is oftentimes a neurological phenomenon, not something that's going to benefit from strengthening, but it will benefit by restoring normal micromotion. And the results are immediate and they are dramatic, okay? Typical example, people with weak upper trap muscles, mid and upper trap being weak, rhomboids testing weak, and they present with a chronic compression of the AC joint. And I test it by springing obliquely posterolateral, okay? So I hook the shoulder, and if I can't take up the slack, I know I can't spring it. A lot of our population has that, and they're being told to stretch their pectorals, massage the pectorals, strengthen the upper back, but they're still compressed, okay? It's not gonna work. You can't override a reflex. by simply opening up that movement passively. You could have them lay on their stomach on 3-inch diameter foam for the course of 3 minutes, and that gaps those joints and restores normal micromotion and removes that muscle inhibition. Okay, so as clinicians, we can be a lot more effective if we look for muscle inhibition rather than name everything weakness. Weakness implies a long-term weakness. It's going to take time to recover, whereas encountering a muscle inhibition, that's easily treated. Okay? So I think what we will do is stop right now. So we'll do a part 1, probably do a part 2, maybe part 3 and 4. That'll be identified in the title. Thank you very much.